Welcome! Today we're flipping the script a bit. We're going to run through a simulated surgical board exam. You're the candidate, I'm your examiner. The topic? A major liver resection. So let's see if you've got what it takes.
All right, let's get right to it. Here's your case. A 65-year-old patient, large liver mass, found by accident. The clock starts now. Before you even dream of picking up a scalpel, what are your absolute first steps? Think big picture, safety, fundamentals. Tell me, what's your first move?
Good! A systematic assessment is exactly what I'm looking for. It's the only way to tackle a case like this. And when we're talking about liver surgery, a systematic approach always starts with the anatomy.
So let's start there. This is a classic viva opener, a real bread and butter question. It's fundamental. So talk to me about the liver's arterial supply and its biliary drainage. Be precise.
Okay, good. As you can see right here, the hepatic arteries and the biliary ducts, they pretty much run side by side. The arteries bring the oxygenated blood in, and the ducts carry the bile out. This is the absolute baseline knowledge we expect you to have down cold.
Excellent. Now, things get a little more interesting because the liver has a dual blood supply. That means it also has a pretty complex venous system. There are two totally distinct sets of veins here. What are they, and what's the job of each?
Exactly right. You have the portal vein, which is bringing all that nutrient-rich blood from the gut, and then you have the three hepatic veins, right, middle, and left, which drain the processed blood out of the liver and into the IVC. You know, this whole vascular map is really the foundation of modern liver surgery. It's what defines those 8 functional segments, and understanding it is how we can do these precise anatomical resections.
Okay, I'm satisfied your anatomy is sound. Now, let's apply that knowledge. Let's get back to our 65-year-old patient. How are you actually going to work them up for what could be a major operation?
Yes, this is the kind of systematic approach we need to see. You start with the basics, history, labs, imaging. Then you have to ask, is this patient fit enough for this huge operation? That's your cardiopulmonary review. And only then do you move on to that absolutely critical discussion for informed consent. You can't skip any of these 4 pillars.
Let's drill down on imaging for a second. What's the gold standard for looking at a liver mass? It's a high-quality, triphasic CT scan, what we call a liver protocol. Why triphasic? Well, because we need to see how that tumor relates to the vessels in all the different phases, arterial, portal venous, and delayed. Oh, and you absolutely 100% have to get a CT of the chest to make sure the disease hasn't spread to the lungs.
All right, the imaging is back and it looks like the tumor can be removed. But, and this is a big but, resectable doesn't just mean it's technically possible. What are the 3 physiological pillars that are going to determine if this patient actually survives the operation and recovers?
That's it. That's the triad you have to be thinking about. First, what's the quality of the liver we're working with? Is it healthy or is it cirrhotic or fatty? Second, how much liver are we going to leave behind? That's the future liver remnant, the FLR. And third, does that remaining liver actually have the oomph to regenerate? If any one of these is off, you're heading straight for postoperative liver failure.
So, what if that FLR is just too small? What's in your toolbox? A top-tier candidate would bring up an adjunct procedure here, something like portal vein embolization, or PVE. Basically, you get interventional radiology to block the portal vein going to the part of the liver you plan to remove. This forces all that blood flow to the other side, the side that's staying, and it makes it grow, hypertrophy, before you even operate. It can make an unsafe operation possible.
Okay, you've done the workup. The patient is a solid candidate. Now you have to decide on the operation, and just as importantly, you have to discuss it all with them.
So, based on the scans, the mass is in the right lobe. This slide here shows the 2 main options. On the left, a right hepatectomy. That's taking segments 5 through 8. And on the right, a left hepatectomy. For our patient, a right hepatectomy is almost certainly the way to go.
This is a core skill. So you're sitting down with the patient and their family. Walk me through that conversation. What specifically are you going to tell them about the procedure, the alternatives, and most importantly, the risks involved?
Okay, that's a good, structured answer. It's really important to separate the risks into these 2 buckets, specific and general. The specific risks, bleeding, bioleak, liver failure, those are the really scary, life-threatening things unique to this operation. But you also have to cover the general risks of any big abdominal surgery, like infections or blood clots. This structured approach shows you're being clear and thorough.
All right, consent is signed, the patient is on the table, asleep. Let's go to the operating room. Talk me through the operation itself.
But before you just start listing steps like you're reading a recipe, what's the core principle of safe liver surgery? What's the one thing you have to keep front and center in your mind? It all comes down to controlling the major blood vessels. That's the key to a safe and successful operation.
Yes, that is the flow, that is the rhythm of a hepatectomy. You start with exposure, get the liver mobilized, then you control the inflow at the hilum, that's the artery and portal vein. Next, you control the outflow, the hepatic vein. And only after you have total vascular control do you actually start dividing the liver itself. Finally, you make sure everything is dry and you close. Perfect. Very good. Now we're getting to the details that really separate the experts. You absolutely have to use intraoperative ultrasound to confirm what you saw in the scans. When you're taking the right-sided structures, you have to be paranoid about identifying and protecting the left-sided ones. And you always have to be on the lookout for weird anatomy, like an accessory right hepatic vein, which can cause massive bleeding if you're not ready for it. The surgery's over, it went well, but you're not out of the woods yet. Managing the patient after the operation is just as critical as the surgery itself.
So you get a call from the resident, it's post-op day 3, they tell you the patient looks great, vital signs are rock solid, but the surgical drain has put out 300 milliliters of greenish, bilious-looking fluid. What is the first thing that pops into your head? What's your top concern?
You got it, a bile leak. Remember that specific complication we talked about during the consent? This is it, happening in real time. It's probably the most common major problem after this operation. Right now, your drain is controlling it. But if it wasn't, that fluid could collect inside and form a biloma, which is a much bigger problem.
Excellent performance. You've navigated this case very well. Now for one final question to pull it all together. Let's go back to the beginning. Same tumor, same patient, but this time they have underlying cirrhosis and portal hypertension. How does that one fact change absolutely everything we've just discussed? How does it change your workup, your threshold for surgery, maybe even whether you offer an operation at all? Think about it.